Welcome to Season 2 of Coming Home to Ourselves, where we aim to bridge the gap between the sacred and modern-day responsibilities, barriers, and life. I am Denise Elysa, your host, channel, mystic, and guide, and I aim to empower you to become your own self-healer and an embodied co-creator of your life, supporting you in shedding what no longer serves and aligning you with your most authentic and connected version of self. Please note that I am not a medical professional and nothing said in this podcast should be misconstrued as medical advice or replacement of such. If you'd like to know more about my background, training, or the workshops, ceremonies, or other work I offer, please visit www.deniseelysa.com. Hi, friends. We have two extra special guests here today, and it's been a dream of mine to have Dr. Ric Arseneau and Dr. Jane McKay join me on my podcast, but I really wish it wasn't in such dire circumstances that we actually came together to do it. As some of you already know, I am a patient at the BC Centre for Long COVID, CFS and Fibromyalgia, and I'm also proud to be a co-facilitator alongside Dr. Arseneau and Dr. McKay in one of the many multidisciplinary groups that their clinic offers. Dr. Ric Arseneau is an academic general internist. He is a clinical professor at UBC and holds an MBA and an MA in adult education. Dr. Arseneau's clinical interests for the past 35 years have included myalgic encephalomyelitis or chronic fatigue syndrome, fibromyalgia, long COVID, and related disorders, as well as eating disorders. He is the former director of program planning and helped set up the Complex Chronic Diseases Program, also known as the CCDP at BC Women's Hospital. He is also trained and certified as a group psychotherapist, and he currently serves as co-director of the BC Centre for Long COVID, CFS and Fibromyalgia, alongside Dr. Jane McKay. Dr. Jane McKay is also a general internal medicine specialist and works as a clinical associate professor at UBC. She developed BC's provincial medical care model for eating disorders and serves as the lead internal medicine specialist for the provincial eating disorder program. Dr. McKay also served as provincial medical director for BC's post-COVID recovery clinics. She joined the complex chronic disease program at BC Women's Hospital in 2016, served as medical director, and in 2023 partnered with Dr. Ric Arseneau to co-direct the BC Centre for Long COVID, CFS and Fibromyalgia, also known as the BC-CLMF. So I can't tell you guys how many doctors and specialists told me that they had no answers for me prior to landing in your guys' clinic. I was consistently dismissed. I was sent for psych evals instead of recognizing any kind of physical illness, or at the very best, I was told that medical science simply had not caught up to my conditions. I left a lot of doctors' visits feeling hopeless and at times often believing that medical-assisted dying, or MAiD, was likely going to become my only dignified solution. The BC-CLMF clinic is truly my only access to safe, effective, and informed, non-privatized medical care. And the group model was a bit of an adjustment for my first appointment or so, but it quickly proved to be significantly higher quality individualized care than any of the hundreds of non-privatized medical visits I'd had prior, due mostly to being unable to find any other specialists that have had the same level of understanding of these conditions. So for our listeners who maybe have never accessed your clinic, maybe they're not living with these conditions, they don't really understand the clinic model or what life is like and the limitations and barriers are like to people who are living with these conditions, can you share a little bit about what's different about it and why it's so effective?
So from a perspective as a clinician, Ric and I both recognized that the patient population that we see really needs a unique and innovative model for care delivery. We provide individual care, and also we provide a group model of care that involves a multidisciplinary or interdisciplinary team that is integral to the success of what we provide. The group medical visits or allied sessions are an opportunity to engage, to learn, and also what we have found is the shared experience of one another helps tremendously in the delivery of care. So for any individual coming to see us, would start in our group model right away on referral and be able to see up to 17 different allied professionals that are uniquely chosen with the skill set to manage the illnesses that we see. And while participating, their care begins and process for improvement begins in quality of life and relationships and health. We will see an individual one-on-one, and along the process, all the time that an individual is with our clinic, they will have access to individual care and group modeled care. So it's unique, it's successful, and it really, really works for individuals that are suffering from fatiguing disorders or disorders that leave them isolated, not able to get into a traditional doctor's appointment, or who live rural or remotely all over British Columbia. So we are continuing to thrive in this process and help our patient population.
Denise, I wish your experience were something that was unique, but there's a study that came out in 2015 that shows that on average, it takes about 5 years to get a diagnosis. And that's the average, which means that some patients go undiagnosed for 10, sometimes even 20 years. And a significant proportion of them, so a Canadian study on POTS, postural orthostatic tachycardia syndrome, one of the conditions that's the related conditions, a Canadian study showed that 95% of these patients get diagnosed with a psychiatric condition before they get the correct diagnosis. So your experience is unfortunately the norm. I think that what Dr. McKay was describing is what I would call the special sauce of our clinic, that it's the people. That the BC-CLMF stands for BC Clinic, but really, I think it stands for the BC community, because I think of our clinic as a community rather than a clinic. And that's why we provide ongoing care, which is impossible to get elsewhere in the province. And so our multidisciplinary team and the people who work with us have a deep understanding of these conditions, either from a lived experience, because like yourself, the majority of the people who run our groups are patients who come to us with special skills. And so every time we come across somebody with a special skill, they say, I'm a grief counselor. Would you like to do a grief group? I do somatic therapy. Would you like to do somatic therapy? And so, because it's not just a question of knowing how to do the special skill or having the special knowledge, but it's how do you integrate it for our population. And, the interesting thing is that most of what Dr. McKay and I know is not available in textbooks. It comes from listening to patients. We've listened to lots of stories. And that's why when we have something called core group, which is the basics about living with these conditions, but we spend 6 weeks listening to stories. And Dr. McKay and I comment on those stories because those stories capture information that our patients can't get from reading. And so there's all these concepts that they kind of go, yeah, that's me. And then they can look at their story and they can look at it from the big picture after the fact and go, my God, this all makes sense now. And so the learning really comes from our patients and our focus on the whole person. So I think, yes, we do the individualized care and we do the group-based care, but our special sauce is the people.
Something I want to highlight there that you just said is how much you learn from the patients and how that's why a lot of other doctors don't have this information because they can't learn it in textbooks. And I think that statement and my experience within the reality of that statement within your clinic truly speaks to how unique this care is and how impossible it is to find anywhere else. I think a lot of people hear group model and think that the doctor is never going to hear you as an individual. But your experience from learning through each of your patients and being able to take that knowledge and implement it into their treatment plan is a direct reflection of how much individualized care you are actually able to offer through the group model.
Well, there's an old metaphor that the textbooks are like maps, and the maps are kind of like for sailing. But if you don't listen to the patients and you don't learn from the patients, it's like not going to sea at all. It's just learning from maps. And unfortunately, a lot of our colleagues, they're busy, they're pressured because of the realities of medicine. They don't have time to listen to their patients. Dr. McKay and I have been listening over decades. And so we have a really clear understanding of all the different variations of presentation. And in fact, often we're ahead of the curve. So for instance, when you were listening to some of the stories in core group, some people have this dating back to childhood, and some people have this develop slowly. But up until recently, you couldn't make a diagnosis of chronic fatigue syndrome unless you had an acute onset. But we knew that wasn't right. And until 2016, you weren't allowed to have fibromyalgia as well as rheumatoid arthritis or another pain condition. We knew that wasn't right. So often we hear the stories, we get the concepts, but it takes a long time for the medical system to catch up. It's kind of like with COVID. Dr. McKay and I knew in the first week of the pandemic, we're going to see about 10% of people come with a post-viral syndrome. We didn't realize they were going to muck up the language by calling it something different and confusing it with post-COVID. But that was something that we knew because we've been seeing post-viral syndromes for decades. So reality is overnight, without doing any extra training, we became experts in long COVID, not post-COVID, but long COVID.
Mm-hmm. I just want to share that core group changed my life. Core group was one of the most effective treatment options that I have ever experienced because it taught me how to manage a lot of my conditions myself. Because a lot of these conditions that we're living with, there's certain medications that can help, there's certain treatment plans that can help, but these are lifelong conditions for the most part, right? That you're going to be managing throughout your life. And so core group and the experience and the learning about my conditions and about how to self-manage my conditions completely changed how I move through my day, how I plan my calendar, how I plan my life, right? And that is absolutely the most effective treatment that I have had.
And that's something that we are hearing back from from the individuals like yourself, Denise, how valuable the unique skill set of learning unique skills within the illness itself in the context of others sharing. So it's also, the core group is a model of shared experience, learning from others, but also a unique curriculum that really makes a difference in going forward with management of illness.
And a big differentiating piece that I feel like is important here, because the CTV news reporter earlier this week asked me, "Oh, you must get so much out of like the camaraderie of the groups." And I was like, absolutely not. That is not the point of these groups. I can get a support group anywhere. This is not a support group. This is a treatment plan that happens to be in a group setting where, yeah, I can benefit from other people's stories and shared experiences. And there's massive value in other people asking the questions that I haven't even thought of yet, right? And being able to learn through that. But there's a big emphasis in my own experience from just the presentations from the co-facilitators and the doctors, and how I'm learning to implement those tools and strategies into my own life for self-management.
That's what's really important, right? Because some of the programs have occupational therapists, physiotherapists who teach pacing, but they teach it from the abstract. They don't teach it in the context of patient lived experience and reality, because we knew that we can't teach pacing without dealing with the barriers to pacing.
Yeah.
Because often what you're left with is, here's the ideal pacing, and this is what you should do. So patients are left self-critical, and they put themselves down for not being able to pace correctly. But when you acknowledge that pacing is different when it hits the pavement, that it's got to be reality based. And for some of our patients with the wide eye, they've just been diagnosed. Some of them are just there to kind of like listen. Like a patient told me early on in my career, they said, "Doctor, let me have my healthy denial just a little bit longer." And so for some patients, the shock is they do it more than once because the shock is just kind of like, wow. And then, there's psychological barriers, there's grief, there's acceptance, there's guilt, there's overwhelm. And then we also have other ways of dealing with the barriers. What happens if you're trying to pace, but you have children or individuals with special needs or elderly adults? Or what happens if you're like most of our patients, 78% don't work and a large proportion live near the poverty line? What happens if you have barriers that are financial? Or what if you have human resource barriers like, I don't have family or friends, or my family and friends don't believe me and don't want to help?
Oh, that's a big one.
Helping people learn to pace within that reality context, as opposed to just, here's the ideas of pacing and go and implement them. And that's why listening to the stories and having people who have the lived experience makes such a difference. Like I said, it's the people that make our program.
Well, Ric, you highlighted a piece for me there that is very significant, and it leads right into one of the challenges that I'm seeing with this new policy is you're recognizing the barriers. And that's a piece that I find a lot of doctors that I've seen don't recognize those barriers. It's like, here's your solution. If you can't implement it, you're doing something wrong and it's your fault that you're sick, instead of recognizing all of these very real life barriers that are creating challenges within that. In regards to this policy change that is coming in with the fee codes, one of the most shocking parts, in my perspective, to this policy change is the blatant discrimination against physically disabled and rural living patients who may not have the resources to travel. So correct me if I'm wrong, but it's my understanding that this new feed code change being implemented by the Ministry of Health is capping virtual medical care group visits while the in-person groups remain unlimited. And I know for myself and most of the patients that I know, accessing in-person care is a massive barrier.
I agree. That is a striking, glaring mistake, that discrimination against individuals that cannot come to appointments that have a disability is, as we know, one of the tenets that is not allowed in our current society. So knowing that there is no limit for the relatively more well individual, but the more ill, disabled individual that can't leave their home, that can't get out of bed, that can't shower, is what I think, and I know this is strong language, blatant discrimination.
I agree.
But it's only a question, right? And it's not just rural, remote, and house-bound patients. It's women, because the majority of our patients are women. And it's also for patients who struggle financially. Because recently, actually this week, I had a patient who said, "This is a disease of the privileged." And I said, yes, that if you don't have anybody to help, or you don't have money, or you don't. And for a lot of our patients, the financial and the living aspect, if they can't deal with that, how the hell are they going to have time and energy to deal with their illness?
Exactly.
And most of them, our patients, can't afford to see a physiotherapist, an occupational therapist, a dietitian, a counselor, and because of the way our system is set up. So the group model allows us to have that whole spectrum of team covered for our patients. The that also leads to what a huge part of our work, not the favorite part, but a huge part of our work is getting patients the money they are entitled to. Patients with these conditions are more likely to have been denied from disability because often they don't have a diagnosis. And often, if the insurance company pushes back, the family doctor doesn't have the experience on how to help patients navigate the appeal. And so just this last week, I wrote 10 appeal letters. And in the last couple of years, the last 4 years, we have successfully appealed 350 patients' appeals for disability, whether that's long-term disability, CPP disability, DTC. That's life-changing. Like that's
Yeah.
millions of dollars. And on top of that, we have helped 900 patients get disability. And that's not necessarily one type. Often patients are eligible for 2 or 3 types. And often patients don't know what they're eligible for.
Mm-hmm.
So that's like one of the foundations of if we can't get you financially secure, we're going to have a hard time to help you. And and that's why it's striking that it's the NDP that think of themselves as the group for equality and for fairness, and that the Greens and the Conservatives agree. How often does that agree? Does that happen?
Yeah.
But the supposed group that is the party of the people is actually the root of this highly discriminatory age. And so I'm sorry, I'm getting angry, but
This is worth being angry over. This is
yes,
people's lives are on the line. Like you just mentioned that it's, financially lots of money at stake for people who can't access disability, but it's not just life changing in regards to finances, it's life saving, because the unfortunate reality for people who cannot work, cannot get out of bed, they have to choose between, can I get help to shower today or can I get help to eat a meal today? Like these are the choices these people are living with every single day. So now you've taken away their access to financial security. And let's face it, even if they're on disability, you're still living in poverty in this
yes,
province or in this country. And so their access to care is being threatened. Their access to financial support and security is being threatened. And so what do these people do? If you have no money, you can't work, you end up on the street, you end up in potentially like a medical facility from the province, you end like there's no options really for you. And so what do people do?
yeah. We've had a number of patients who have applied for MAiD.
Exactly. Exactly. And that's where I see this going. And when this conversation started happening several months ago with these policies beginning to be talked about and coming into place, and patients were starting to understand what kind of an impact this was going to have in losing their access to care, all of a sudden I saw this massive uptick in conversations and questions between patients in like text chats and things like that about MAiD. Will I have access to MAiD when this goes through? Because I have no option left. People are going to die over this, in my opinion.
It's heartbreaking to hear that, but what the conversations that are coming up from individuals that we see is this very conversation is, will I be eligible for MAiD? And it's very heartbreaking when you are a care provider that can make a difference for that individual, but your hands are being tied in what seems to be very curious, unclear reasons. And the ones that suffer are our patients, our individuals that we care for. And it is heart. All I can say over and over again, it's heartbreaking from a physician perspective.
That's one
To
of the
Go ahead.
that's one of the main worries about MAiD, right? Is that it becomes a choice for people who can't get secure housing, secure support, or adequate medical care. And we're seeing it live in action.
Yeah, I agree. It's what I'm seeing too behind the scenes within patient conversations. And I want to go back to the note about being able to access in-person care, because one of the things that you mentioned was a lot of patients are bedbound, they're unable to get to in-person appointments. They don't have maybe they don't have the resources to do it. That was another thing mentioned. Like if you live rurally, you don't necessarily have the resources to travel. When I was at my sickest, I was fully bedbound, unable to speak or eat. So my partner had to stay home from work to take care of me, to get me to the bathroom, to try to get little bits of like food or water into me. My parents had to take my, at the time, under 3-year-old for every day for 2 months until we could get her into daycare, because there was no way for, obviously I couldn't take care of her, and my husband had to suddenly attempt to work from home while caregiving me. And so for me to have accessed in-person care at that time would have been completely impossible.
Yeah.
And it would have required me to bring a caregiver with me to every single appointment, not only to get me there, but also to communicate for me within the appointment and to help me up the stairs or into the building or through the parking lot, right? And so by the time I took core group, I was now like, my speech was coming back, my ability to eat was not great, but it was sort of there. But I was still completely bedbound. I took core group from bed. I would not have, under any circumstances, been able to access that in person.
Well, and what you're talking about also is the social benefit of our clinic, right? It benefits more than just patients. And that's why we're really surprised that the Ministry of Health and the doctors of BC have not really embraced the report by MNP. MNP is a very well-respected consulting firm, and they have been used by the Ministry of Health and by the doctors of BC. But when we met with the Ministry of Health, they basically disregarded the MNP report without having read it. And so it tells you that they're already fixed in their position.
Sounds like most of my doctor's appointments before you.
But MNP has determined that for every dollar that is spent on our clinic, that $6.85 of social benefit is generated. And part of that social benefit is people not having to take half a day off and driving their family members to appointments. It includes getting services like OTPT to patients who couldn't afford it. It includes getting insurance payments, disability payments to patients who couldn't achieve it. So it's determined by MNP using what's called the social return on investment that we generate about $7.5 million of benefit for patients, including all of the things that we put together. And the Ministry of Health right now is trying to say this is greedy doctors, and trying to say this is fiscal responsibility. And that's disingenuous, because our model saves money. Our model saves the ministry, the MSP $1.2 million a year. And it frees up family doctors, specialists, emergency rooms to do what they do best. And that's why Dr. McKay and I have what we call a shared care model. We work side by side with the GP. We let the GP do what they really do well, which is primary care, and we do the complex care. Also, we take off the table the GP having to do the paperwork. So I think it's about 85% of our patients who rely on us to do their paperwork, compared to 15% who use their GPs.
You've just touched on so many of the points that I cannot fathom within this situation, because, and I'll touch on the GP one because it's fresh on my mind. When I first found out that these changes were happening, I called my GP, I got an appointment, and I said, I'm going to need you to take over all of my medications from here on out. are you able to do that for me? Because I'm not going to have access to these medications anymore. And she was like, I am not equipped to do that. Like, she just flat out said, I don't understand your conditions in the way that Dr. Ric and Dr. Jane do. I don't understand all of these medications and how they interact with your conditions. And she said to me, I'm going to do whatever I can to help you in this situation, but I need to be fully transparent that I am not equipped for this. So she ended up setting me up with a clinical pharmacist. We then had 5 one-on-one appointments, and we have another one upcoming to go through my full medication list, top to bottom, to break it down, to make sure that what I was on was appropriate, that nothing was, misdosed or whatever, so that my GP could feel even remotely comfortable beginning this process with me. She was not impressed. And she's lovely and she's willing to work with me in whatever way she can, but GPs are not equipped for this. This is not their role.
I think, if correct me if I'm wrong, Ric, but the College of Family Doctors of British Columbia actually do support us.
Yeah,
And
and the
are
Specialist
really,
Society.
and the Specialist Society as well. So they do have a vested interest in us continuing, and they want us to continue to help. So we are hoping that will speak to help going forward, but that hasn't transmitted to help in the Ministry of hearing that message. But you're right. I think a primary care practitioner without support from someone like Dr. Arseneau or myself is going to struggle. And that is unfortunate and not necessary.
That's also why we have what's called our primary care toolkit. The 2 clicks on our website. Resources, primary care toolkits. We have diagnostic criteria. We have medication handouts because we use medications differently. So all of those things, and in each of our consults, we put a link to our primary care toolkit. So to help family physicians who are interested to learn more about this, because some are. So for instance, Dr. Karina Zeidler is a family physician who takes care of a lot of trans patients. And what's interesting, she has noticed the same thing as us, which is that trans patients are more likely to develop these conditions. It's not in the literature, it's just something that we've noticed. And we both think that it has to do with the role of adverse childhood experiences. And so we have the whole spectrum. We have Dr. Zeidler, who came and did core group. And so she spent 16 weeks learning about this and listening to the patients. And then at the other hand, we have patients who've actually been fired and explicitly told, if you want to work with Dr. McKay or Dr. Arseneau, I will not be your family doctor. These are not real conditions.
So that wasn't specifically my situation because this was prior to your clinic, but I felt like my old GP was leaving me to die at 24 years old. That's how I felt when I was first becoming really sick and just getting sent for psych evals instead of recognizing any of these things as real conditions and refusing to read specialist reports when they got sent to him and stuff. So this is a major issue. I feel incredibly lucky and privileged to have landed the GP that I currently have because I know how bad it can get. And I talk to patients all the time who either don't have a GP at all, have been fired by their GPs because of situations like this, or just simply don't feel safe to go see their GP. I think that this situation is going to flood the medical system in the ERs, in the GP offices, in all of the specialists. I used to see my GP multiple times a month to attempt to manage these conditions. And now I see her like a few times as needed because my conditions are managed through the support of your clinic.
Well, and if you count the numbers, right, we have 6,000 active patients. And we looked in the last 2 years, we had 2,000 referrals per year. Luckily, we have 2 doctors who have had remissions who are joining us. And so a lot of the people who've had remissions in our clinic are actually medical practitioners. And what's interesting is, I'm sure she won't mind me saying this, but Dr. Lana Diamond, when she did core group, she apologized to the group. She said, I was one of the family doctors who thought you were all lazy. And so she feels like this is my contrition. It's important to realize this is not going away. So 2,000 referrals per year in the last 2 years. And Dr. McKay has sent to the ministry and to doctors in BC the graph of the projections for the numbers into 2027. Because there's an article that came out maybe last year and it said, what's the biggest impact of COVID on society? And the answer was COVID amnesia. Nobody wants to hell hear about this anymore. And that's why we were stunned when Bonnie Henry said the pandemic is over, because that's a blatant lie. And at the same time, WorkSafe BC said, well, if that pandemic is over, any doctor or nurse who gets COVID will no longer be covered by WorkSafe BC. I sent this out as a press release, but it was not interesting enough to be picked up.
This is one of the challenges I have with like the news and the media, right? Earlier this week, Rick, you were interviewed for CTV News. I was interviewed for CTV News. There was another patient, and I turned on the news that night, really looking forward to the interview, feeling like some of our really important points were going to be expressed. And so much of what I spoke to the interviewer about was cut out, right? It's cut, whole news stories are cut down to 2-minute segments where everybody has like maybe 10 seconds to share their piece. And there's no room for nuance. There's no room for clarity. And then that's all the people are receiving, unless they're behind the scenes with us starting to learn this stuff. That's all they know, and that's all they have to go off of. So I have a question for you guys. Prior to this policy change, both virtual and in-person groups were unlimited for a number of patients who could attend, was my understanding. And I've heard of some programs running them with up to 800 to 1,000 patients. So what are your thoughts on that?
Yeah, I don't want to with other clinics, but it seems like you want to look into that. It doesn't seem reasonable. But we've had groups as big as 150. In fact, we have calculated what we think is the maximum we should charge. And so for our special lectures every week, and our special lectures, 50% of them end up on our YouTube channel. And our YouTube channel gets 3,000 individual separate people come every month. And it's worldwide because 40% come from outside of Canada. And so the impact of that is huge. But we have as many as 500 people show up. We don't bill for 500 people. We still have to write a note on 500 people, and we have to document that they've been to that. So there's lots of administrative cost and trying to coordinate 500 people. But what we do is we only bill for 150. And so because we think that that covers the cost of the administration of running those groups. And in the end, it's really cheap when you look at, our family and friends presentation has been watched 21,000 times. And our POTS presentation, it's amazing how little information there is about POTS out there. And Dr. McKay is a super expert on POTS. I'm her kind of assistant, or POTS assistant. That's one of the ones that's actually watched the most from people outside of province and outside of the country, because we have really practical approaches that don't require a lot of doctor time. And that's another way that we save money. So for instance, patients who have mast cell activation syndrome, or patients who have POTS, postural orthostatic tachycardia syndrome, the usual thing, they come up to their family doctors, they have unusual symptoms, they get sent to a cardiologist or a neurologist or a immunologist, allergist. They may or may not get gaslit. They may or may not get an answer to their questions, but many of them get extensive investigations that are unnecessary. And so if you look at the cost of that, whereas these are things, and we have very self-directed patients. You go to our website, you click on new patient, you scroll down, it says, I think I have POTS, what should I do? I think I have MCAS, what should I do? And so we get patients to watch the video, we get patients to do a test at home, we confirm the results of the test in a visit, then we send them to a group medication visit where we can have same patients deal with the same issues, which makes it easy to talk about the medication. So it's all streamlined. And it costs the province pennies on the dollar of having them go through a tilt table test, see a neurologist on top of waiting 8 months, right? Because what we know for sure with these conditions is that early access to care leads to better outcomes.
Yeah, absolutely.
So you go to one of the other clinics and they tell you it's 3-year to 5-year wait list. You come to our clinic and the day that you are referred, you are able to participate. And because you can get into group medical visits within 1 to 3 weeks, it means you can talk to me or Jane within 1 to 3 weeks. And
It's so life-changing.
Despite the fact that we have 6,000 patients, the patients can see us faster than they can see the GP because they can get to see us within 1 to 3 weeks for a group visit. And the group visit is 10 or 12 people. Everybody learns from each other's questions. But if we can't solve the issue in the group, we book an individual visit. And that usually happens within 1 to 2 weeks. So in terms of access, our clinic has kind of like figured out how to scalably deal with a large population, but not make people wait crazy amounts of time to ask questions or to get care.
That's been one of the wild differences for me, is the quick access to care when I need it. Because if I have a situation arise with one of my conditions that I'm going to be managing throughout my life, I need access fairly quickly to be able to navigate whatever that piece is, right?
Yeah.
So currently, to put this into perspective, I waited 2 years for a different specialist that I'm seeing right now. And now I'm waiting like 8 to 10 months for a basic follow-up. And she already doesn't seem like she can help me, like from our first appointment. And yet still I have to wait the 8 to 10 months for my basic follow-up. And I can't be referred to somebody else for a second opinion in the meantime because my referrals have been denied because the system is so overburdened that they can't take second opinions.
And that's why if you think of being even worsely overburdened by us now not seeing those patients for those conditions. Sorry, Jane?
No, I was just going to say and that explains completely why an innovative model like this is so necessary in today's society of healthcare delivery. And what I'm constantly amazed every time someone comes to my group medical visits that's new, how they say, well, I'm new to this whole process, and I just kind of welcome them, introduce them to what they can do, and they are shocked and happy. And I think that it just speaks to how we do have to be innovative. We have to develop models of care that help individuals in a different way. I wanted to go back to a couple of things that I think are very important. You talked about your CTV interview with the media and how disappointed you are. One of the disappointing factors of some of these media presentations is points taken out of context. So when I heard the health minister talk about cost containment as a soundbite from an office with no counter questioning, I was quite frankly shocked that was the approach that was taken, because it really is a point out of context. And so I think that's an important point to hear, is that sometimes the media presentations with government officials are biased and out of context. And I want all individuals to know that that's happening.
From here, I have a quote from her here to ask you about later in this conversation that I want your thoughts on.
The other thing is, you have never heard the Minister of Health or doctors of BC address patient experience. It's almost like it does not exist. And that's really the center of all of this, right? So it's like, oh, dollars this, greedy doctors that, fiscal responsibility. But that's why we're confused. Now, we talk about access. We have a program that allows almost instant access, that's equity-based, that's trauma-informed, that provides a shared care model for family doctors, that is cost savings to the ministry, and that opens up spaces in family doctors, emerges, and specialists. So why are we having to fight? Why are they not saying, we have a shortage of doctors, and this is a model that works, and it's a model that's cost effective, and it's a model that deals with the lack of doctors, because doctors of BC, their old guard of 1950s mentality want us to get back to good old fashioned in-person individual visits. And somebody should just say, who's going to do that? Who?
Yep.
And are they distributed across the province? And so the reality is that for most of our patients, it's not a question of in-person individualized care. It's a question of group medical virtual visits or no care.
Exactly. And not only that, once I'm connected with your clinic for my lifelong condition, I'm not cut off after a year, right? So if I was to attempt to access even remotely similar style of care or specialist work for these conditions, I would likely be losing access to that care a year in or so. And then I still have to continue to live my life with these conditions and not have any medical professional to support me with them.
Well, that's where the multidisciplinary piece comes in, right? The Canadian Medical Association just in the last month released an article that said one way to deal with doctor shortage is multidisciplinary, interdisciplinary care. That's exactly what we're doing, is we're sharing the care with a bunch of people who not only will help us see more patients, but help us provide better and more varied care. And the other thing is about, the being able to access quickly, is people say, well, how is your model sustainable? Well, the reality is that most patients spent the first 1 to 2 years accessing most of the resources and getting stabilized. And then we're in the back pocket in case they need us. So we have some patients now who come once a year because they need their paperwork done, or they haven't come for 2 years, but now they have a new symptom and they get in within 1 to 3 weeks. And then we can help them navigate that. And so part of the thing is just when Dr. McKay and I worked at the CCDP, one of the things that we always saw, we always did exit interviews with patients, was anxiety around, what am I going to do now?
Yeah.
Because you guys understand, but it's taken me forever to get to this level of care and nobody understands. So what am I going to do when I get a new symptom, or when I have a problem, or my doctor refuses to fill out my paperwork? And so, the interesting thing is that all of these innovations that we've put in place, some of them and most of them are free, like allow patients to participate immediately. We presented them to the CCDP, but then we were told that they were not feasible. And yet here we are, having implemented all of these ideas very successfully.
This really hits home for me because for myself, my experience throughout your clinic was that I did the core group, I did a bunch of other groups or seminars that felt related to my conditions. I started to implement things one by one. I went from not being able to enter a public building because my lips would tingle, my mouth would swell, I would get the globus sensation and start to feel like I was struggling to swallow. And then I would be followed with severe digestive issues, and that was because of fragrance in the different public buildings. And I went from that to being able to safely go into friends' homes, safely have friends into my home, safely go into the grocery store and pick up a couple of things, right? So through accessing those groups, I was able to significantly change my life. And not only the groups, but also those resources you mentioned. And I cannot tell you how many people who are not your patients who I send your resources to, like almost weekly, because I have people all the time reaching out to me talking about these comorbidities that they cannot find access to care for. So I send them your resources so that they can take them to their GP or whoever is working with them, and they can attempt to get support. But then what happened for me through going through your clinic was I was able to take a little bit of space from some of the groups. You get to a point where you're like, I don't need to be accessing this all the time anymore because I am
I could teach
equipped.
this like
Yeah, because
you
I
do.
am equipped to manage this on my own for the time
Yeah.
being. And then I live my life like that for a little while, and I start to notice, oh, this other symptom is still lingering, even though I've done these other things. I wonder what that's about. And then I pop back into a medical visit, or I take a new group, or whatever it may be, so that now I can work on this next layer that is still there. Because when you're living with all of these compounding conditions, you have so many overlapping symptoms that it can be really hard to flesh out what's what. And it can become really overwhelming when you feel like you have to deal with it all at once because you only have 12 months to do it.
Yeah.
Right?
That's
So go ahead.
well, you also brought up one of the elephant in the room, which is outcomes, right? Is that for anybody who wants to learn about the outcomes for our clinic, have a look at the MNP report, and it's on our website. And I'm sure that you'll be able to put that up for people at the
I'm
end.
going to link it. Don't worry.
Perfect. And so it's unusual for people to be able to return to work or even get better, because one of the clinics published their results recently, and they showed that apart from a bit of support that people get and they feel connected, that there was no substantive improvement in symptoms. 17% of our patients get back to work, and 88% of them report substantive improvement, exactly like
Wow.
you've described. And part of that is because you can't just do one thing. You can't just do long COVID or ME or FM. You've also got to look at all the other pieces. Do they have mast cell activation syndrome? That's something. Do they have POTS? That's something. And one of the patients, we talk about central sensitivity syndromes, not a separate syndrome, but a family of conditions. And in our clinic, the average is 6. On top of that, people have hypermobility and will have mast cell activation syndrome. And when at the end of the appointment, the patient said to me, "Why are you giving me this alphabet soup of acronyms?" And what I said was that each of these acronyms identifies a lever that we can pull to make you better. We treat your PTSD, you get better. We treat your MCAS, you get better. Not just the MCAS gets better, but the big picture. We treat your POTS, you get better. We treat your pain, you get better. We treat your sleep, you get better. You treat your migraines, you get better. We treat your IBS, you get better. We treat your gastroparesis, you get better. And incrementally, all of these things add up. But unless the program is designed and allows patients to access all these things, plus, I'm sure you're familiar with this, some patients come to our clinic and they're like, wow, I want to do everything right away. And they get overwhelmed. And so that's why 1 year and one shot at something is not realistic. And
No.
that's why we have a hierarchy of, okay, this is first, then this, then this, then this. Take your time, take as much time as you need. Because, one of our patients who went to the post-COVID clinic was told, like, make sure you sign up for everything because it takes a long time to get everything. So when she came to our clinic, she signed up for everything and then realized, oh my God, I can't do everything. And so it's like, yes, take your time and learn and take what you've learned. Because in our mind, there's 3 aspects to care. Most patients come to us on a decline. For most patients, the story is, okay, no social life. Okay, no personal life. Okay, no, my house is not as clean. Okay, I can't shower every day, and then I stop work. And then sometimes they even continue to decline. So first step is stop the decline, stabilize. The second step is optimize all the symptoms. And the third step is help patients get into remission. Mm-hmm. And those require three very distinct approaches. And I'm not sure that other clinics are even aware of these distinctions because, unfortunately, when I worked at the CCDP, I was not allowed to use the word trauma, and I was not allowed to use the word neuroplasticity. I was specifically told not to use those words.
It's such a disservice. Go ahead, Jane.
I was just going to say I have to chuckle because we're looking at the holistic approach to management of individual parts of an individual, and each one is unique, and trying to provide the support that they need in the moment that they need it, which is not everything all at once. And I think that's what I chuckle because Dr. Arseneau had the hand up, and I also have the hand up a lot, like the first it's this, and then it's this, and then it's this.
And I was picturing this exact conversation as I was like sitting with this podcast episode earlier. I thought I have to find a way for them to bring in their methods of how when we enter the clinic, we're going like this. And it was the hand motion that I had in my mind. When we enter the clinic, we're going like this. They get us to come like this, and then they raise our ceiling so that we can come here. And so I'm glad that that came up. I want to ask you, in our CTV News story earlier this week, Josie Osborne, the Minister of Health, stated in her interview that they're not limiting the ability for it to be provided virtually, but it is important that we put some parameters around this program for physicians so that it's being delivered in a way that is fiscally responsible. But from what I've been hearing, this cap is likely to cost the health system way more money and offer increasingly worse outcomes throughout all areas of our already crumbling health system and create a higher tax burden in the process. So what are your thoughts on that?
I wanted to comment on that specifically because I think that's the issue with those sound bites and not in considering the unintended the consequences of actions. And we've been very clear, this will cost more. Patients will be going to emergency. Patients will be seeing doctors, family doctors, if they have them. They will be getting worse. They will start using ambulance services to go to emergency because they cannot get out of bed.
Yeah.
So the cost factor and fiscal responsibility, the mismatch in what's being said is, for lack of a better word, I call it political speak because I just don't understand it, and I wish I wish that healthcare ministers that we have or others could be more open and more willing to meet with us in a way that we could respectfully work together to help care.
Let's call it what it is. It's misinformation and disinformation.
Yeah.
And it's to push a political point. And the reality is right now we're talking about our clinic, but it's not just us.
I know.
The reason that we're at the center of this is because our model survives on the group. Other clinics have groups, but their clinic doesn't survive whether or not based on the group size. So, for instance, one of our colleagues, Dr. Brenda Lau, who's famous across the country as one of the premier pain experts and runs the Change Pain Clinic, she's equally concerned that she won't be able to provide care. The thing is that groups are only a small portion of what she does, and so her patients are not as up in arms as ours are. But it will not only affect us. So it's not just our patients who are going to end up in emerge. It's going to be the patients from the Change Pain Clinic and from other pain clinics and other programs across the province, because just like us, those programs often use the group models to provide care that's not available as part of a multidisciplinary program, as part of a way of dealing with the physician shortage, which is one of the very well-known ways of dealing with that. So at first, I was, like I usually am, very naive. And I thought, all we need to do is to get to the right people, and it won't take us more than 5 minutes to get them convinced that, hey, this is important. And the fact that it hasn't, and when Dr. McKay and I first met with the Ministry of Health delegates in August, it was a very different story. They were like, yeah, this is a really good program. And yeah, it's really helpful. We need to help you figure out we need to help you figure out how you're going to continue this. And then they never got back to us. And then they waited until last week to have a meeting. And now their position is very different. They came in hostile. They said that our program was not any better than glorified webinars, and that we should just put a Q&A session on our website. They also said that we can't provide individualized care, despite the fact that they have no idea what we do, and despite the fact that our clinic has been reviewed for 18 months by the College of Physicians and Surgeons. And one of the comments at the end, it took them so long because they had to wrap their head around this different model. But at the end, they basically said that you guys are providing excellent individualized care within the group setting. So doctors of BC and the Ministry of Health don't determine what good care is, yet they're making comments about it without not knowing it. So I think this is part of their disinformation, misinformation campaign. And so I think keep in mind, it's not just us, and that this is not really a political thing. The doctors of BC are clearly, they've actually even had a campaign about getting back to in-person care and getting away from virtual care. And they're making comments like, we only use this because of the pandemic, and now we need to go back to the old care. Well, the reality is that we should have been doing this all along, but it takes doctors forever to implement anything, and that the pandemic allowed us to move quickly with good ideas that should no longer be abandoned. But now they're saying, oh, no, let's go back to the old. And at the same time, they are funding virtual programs across the province. So there's a new program coming up with emergencies, combining virtual and in-person care. So this is political, unfortunately.
Mm-hmm. And just to highlight the disinformation campaign, there has been a 100% virtual group medical visit program, and I feel that we can say the name Lifestyle RX, that the MSP has funded, continues to fund, and it's all virtual, and it has group medical visits that are 30. So you can imagine how confused we are and about the mixed messaging that's out there, and why our patients are being targeted, our population, our clinic. And to speak back to what Ric was saying about other programs, Dr. Lau is an international expert on chronic pain. She hasn't told anyone, but 1 in 5 people in British Columbia suffer from chronic pain. Her model is an integrated model, as like ours, and does depend on the group medical visits. So that's going to impact 1 in 5 British Columbians who live with chronic pain. So this is not just our program, it's many people. And the mixed messaging, the difficulties that we're hearing really, as Ric has pointed out, is disinformation.
And let's address one of the other disinformation, because the minister said for 1 hour they can make this amount of money. Well, that's not really true. Because, for instance, if we do a group medication visit for 50 people, it's around $1,400. And like, well, that's a lot of money for 1 hour. Well, after the visit, Dr. McKay and I have to review 50 charts. We have to write 50 notes. We have to write 50 prescriptions. We have to send those notes to our patients. We share everything with our patient, and then to the referring doctors. So that's about 5 hours. And so if you actually look at what they're recommending, doing individual visits, Dr. McKay and I could, over that 6-hour period, see about 36 patients individually at a cost of $2,000 extra of what we bill. So if this was really about a money grab, why wouldn't we want to make an extra $2,000 for the 5 hours that we do?
Okay, so this was exactly one of the things that I have been reflecting on throughout this whole thing. I was really hesitant to get involved with the advocacy around this because I live with these conditions, and that means that I have to manage my spoons in order to survive my life, in order to be able to show up in my life. And so I wasn't going to take on the advocacy around this because in my mind, it was a no-brainer that this policy wasn't going to go through. So I wasn't really worried about it beyond putting into place the things with my GP that I needed to put into place to protect myself in case it did. But I couldn't fathom it didn't seem logical at all for this policy to actually go through. And when I sat with it, I thought the exact same thing that you just said, that if this was about money, Dr. Ric and Dr. Jane would just stop seeing us in groups. They'd go back to their one-on-one care. We would wait months or years to see them for our follow-up appointments, and they would make way more money with way less headache and way less other pieces to manage in the background. They could just show up and work with their patients and send them home like every other doctor does, and too bad if our outcomes are not very good.
Well, the other thing too is that's just the one piece. The other piece is for the groups that we run. Those groups allow us to hire OT, PT, a dietitian, counselor, social worker, yoga instructor, which we wouldn't be able to do otherwise. Plus, you might be surprised to hear, but it takes 6 assistants for us to be able to manage 6,000 patients, because one of our assistants gets about 500 emails a day. And so the administrative cost is huge compared to if we only saw a patient once or twice and sent them back to their family doctor. So it's insulting that this is being portrayed as a money grab by greedy doctors. But even sadder is, why is this conversation about money anyway? Why is the minister not addressing patient experience, patient care, equity, and need? It just so happens that we're cheaper and we save money and we save resources. But it's interesting that the disinformation is coming around that piece. So, and like you said, how do we get this across? We get a news interview, and like Dr. McKay said, we get a soundbite, and then the Ministry of Health gets a soundbite, which just says, yeah, these are just the greedy doctors. We have to be fiscally responsible. The reality is, if they were fiscally responsible, they wouldn't have screwed around for 9 months, 6 months to decide that, like you said, it's a no-brainer. And that's why I mentioned that I was naive at the beginning, thinking, give me 5 minutes, I'll explain it, and everybody will go, yeah. And that's what happened in our first meeting with the Ministry of Health. But something in between happened, that they're getting pressure to kill this. And it's a false sense of economy. We agree that maybe 800 is probably a bit too much.
Yeah.
But we're not asking for 800. We're not asking for 100. We're not asking for 75. We're asking for 50. And the College of Physicians has said that we can provide adequate one-on-one individualized care for these patients. So I'm hoping that our listeners will balk at the disinformation and simply ask, when Minister of Health talks about the fiscal responsibility, that somebody says, fiscal responsibility, let's leave that aside. What about the patients? What are the patients going to do when this care goes away? And get her to specifically focus on that question as opposed to hiding under misinformation about fiscal responsibility. Sorry, I'm rambling.
That's okay. It's also, what impact is this continuous delay having on the patients? Because I know it's impacting my health. I know it's impacting the other patients too, right? We're living with conditions where stress alone can cause us a complete relapse. And there's such a survival threat involved to our health and our lives in this situation. So not only is our experience, our care, our lives not being considered in the policy change, but it's also being completely avoided within how they've gone about it and the extending of these timeframes.
Yeah.
So,
and that's the thing is, some people have said, "Oh, that's great, we got extension." I'm like, no, it's not great. They've just kicked the can.
Yeah.
This is part of playing politics. They're hoping we go away. In fact, the assistant to the minister asked me not to go to the media and asked me not to talk to MLAs because that's what's most effective. And so, of course, we're doubling down. And if it actually does get to the point where it gets, we have to abandon a model, we are going to triple down. Because Dr. McKay and I are committed to this patient population. It's our community. As much as our patients love us, we love our patients. We have, one of the things that is a study that was done, and I wish I would have thought of this because I used to do this with my medical students. I used to say, okay, let's talk about chronic fatigue and fibromyalgia. Let's do a free association. What comes to mind? And the words that came to mind were psychological, that it was not fun to take care of these patients, and that it wasn't rewarding, and that these conditions were not real. And so when Dr. McKay and I had residents at the CCDP, our main goal was not to provide the education, because you could read that stuff. Our main goal was to make them realize, number one, this is real. Number two, it's extremely rewarding to take care of this population. And so, I could improve somebody's, sorry, Jane, because I know you do blood pressure. I could improve somebody's blood pressure by 5 points. Yay! Or I can make life-changing impact on a patient who has gratitude. What better job can you have than the job that Dr. McKay and I have working with this population?
Can either of you clarify for the listeners why you can't run groups at 20 people? Why that is not, like, to clarify for them, why in this situation does lower caps mean no care instead of better care?
Do you want me to take that, Jane?
Yes, Rick.
Go. So, we've kind of figured out how much do we need to be able to cover the cost of 6 assistants and to continue to be able to afford OTPT. So, anything below 50, that's the cutoff point.
Yeah.
And that makes it non-viable. And so the only thing that we're going to be able to do are the new consults and the 10 to 12 group medical visits. There will no longer be group medication visits. There will no longer be any core group, no allied health group, interdisciplinary groups. And so Dr. McKay and I will actually make more money.
Yeah, that's what I thought.
But it's not a question of let's do it with 20 because it's not financially feasible. Plus, if you look at our groups of anywhere from up to 50 or so right now, it would take 2.5 times as much time. So we'd need to have more doctors. And we want to use the more doctors that we're bringing on to be able to do the individual visit with patients sooner, their consult. And so it's not viable. Sorry, Jade.
I was just going to say, not only is it not viable, I think what is being overlooked is there's very few doctors that can do this type of work, are trained to do this type of work, and want to do this type of work. The great news is we're attracting individuals. But the first when I bring things like this up to the residents, so I still do acute care, and when I'm in emergency sitting with the residents in between cases, I'll say, so tell me, what do you know about long COVID? And it's a question mark. They know nothing. So and it's not their fault. It's the how training is organized. So I wanted to bring the segue in. So the only way that Dr. Arseneau and I can train expertise like this is by attracting individuals to come. So Dr. Ric has already has the model ready for the educational impact, and I will be implementing that starting in July. So by March, all of the R4 residents in fourth year of internal medicine or will be able to come work for us in what we call a longitudinal clinic model, and both of us will be able to teach them, and I will take over teaching in the academic program on long COVID, fibromyalgia, and chronic fatigue syndrome that's currently being done by one of our colleagues who has many different hats on. So I'll take that over. So there is that sense and need to build for others, and I'm sure as we build, more will come, and that's what we hope.
You're also discussing the opportunity cost. So this has taken us lots of time to fight. And so we were supposed to implement bringing in the residents on July 1st last year, but we couldn't. And at the same time as we're doing this, we are onboarding a physician, and one of our physicians is coming back after a remission and 17 years of these conditions. And so she needs to get her license back. And in the wings, I have two other physicians who are in remission who want to join us and who will need to do training with me and Dr. McKay to get their license back. These are all things that are kind of like on the back burner because, we don't understand why we have to fight for good care. Why do we have to fight?
And it has such an impact on what we're able to do right now. And we are now put into this position of having to use our clinical time that is desperately important to care for people to actually do advocacy work, primary advocacy work that I've never believed in my entire career I'd have to work so hard to get my patients, I don't like to say that's very patronistic, but the patients, and even the word patient isn't a good word, but individuals care they need. It's about social justice. And what I find is it's very distressing to me that I have to take away all this time for looking after patients to just simply try to get a message across, which is so simple. And anyway, that's my soapbox speech. I want to go back to doing work. I want to go back to training. I want to do what we do best and at least have some certainty of sustainability in the model that is working.
And advocacy for us usually meant something else because advocacy is one of the pillars of being a physician. But for us, that usually meant, making sure we push for care for the patient, making sure we help them with their disability, making sure that we help them get mobility aids, things like that. It never crossed our minds that it would actually mean fight to actually provide care at all.
Exactly. And this is where I find it really, really challenging because physicians should do what physicians do best. Physicians shouldn't have to beat and their heads against the wall to try to keep access going. The population of Canada has 3.5 million long COVID survivors. In 2 years, using StatsCan data that's published and presented at the Long COVID 3 conference in St. John's, will be 10 million. So we're not sitting here saying, we're not making these diseases up. They're there. They're coming. They're worse. We're saying, look at what we've done, and why can't we just get back to business and get on with it and get out of this political quagmire and provide sustainability for these individuals that are suffering from life-changing illnesses on all spectrums of society. And that's my other soapbox speech.
I'm going to ask you, and I think this is going to be a bit of a triggering question for you because you are very passionate about caring for your patients, and that has come through so clearly in every interaction I have had with you. And what's your take on the position that this is putting the patients in? So this is one of like the sickest populations of people. We know that energy expenditure and pacing and managing their energy envelope is one of the biggest pieces that determines if they're going to recover or not. And now all of us have been placed in this position where we are fighting for our lives, not only within our own bodies and these illnesses that we're living with, but within the actual system that is supposed to be treating us.
So people get worse.
Exactly.
The lack of sustainability in this model, the fear factor that everyone is living with, is just works towards firing up more anxiety, which makes illness so much worse. So this is going to cause I feel like this dystopian movie, like all of these things are going to be falling down. All our patients are going to suffer. We don't want that. We don't want that. This is so harmful. And our patients are going to end up in emergency. Our patients are going to ask for MAiD. What is that? Why? Why? I'm sorry if I'm getting a bit engaged, a little bit too stressed, but it's just I'm personally so committed to doing what we do and watching what's happening and living what's happening is terrible.
At the same time, there's the other piece. Dr. McKay and I are overwhelmed with gratitude because
so are your patients.
The patients fight for this because it's not just patients, if they had diabetes or something like that, and who have the normal amount of activity talk, but we're talking about, like you said, bedbound, housebound. 78% of our patients can't work, who are fighting. And traditionally, this patient population has been ignored because they can't organize and they can't advocate because they're so unwell. And so I was really, truly overwhelmed with gratitude to see patients push themselves. And that's why whenever we talk to patients, we say, don't do more than you can do.
Mm-hmm.
Help within the capacity, because it warms my heart to see our patients support us. So, and that's why some of the people out there who don't agree with us have said that we're grooming our patients to tell them what to say and stuff like that, which is hilarious.
It is.
Dr. McKay and I don't know what to say. Don't know what to say in the first place.
No, that we don't know what to say. In fact, and I think it's important to recognize that we are advocating for healthcare services as physicians. The individuals that we care for have self-organized and are doing the work of advocacy on their own. And I am, as Ric says, overwhelmed with gratitude at the effort that's going in to recognize that their needs need to be cared for and are a priority. And I'm so impressed watching the self-organization, the self-advocacy, because we, like this myth that we are running that story is a myth.
Well, let me speak to that one, because I asked you guys, how do you want to go about this podcast? And you're like, you do you. Like, you know, you didn't give me any talking points. You didn't give me any guidance. I worked with another patient to look up, you know, what are the points that are really important to the patients within what's happening right now, and how do the patients want that presented in this podcast episode today with you guys. And I didn't get any input from you. So, you know, and one of the things that I've really witnessed within both of you throughout the last several months and all of this patient-led advocacy is your continued concern for the patients and how much they're doing, and is this within their energy envelope, and do they have the capacity for it? And Jane, like I said to you before we started this episode, I know your doctor instinct is going to kick in, and if I get upset, you're going to want to pause, and you're going to want to take care of me, and you're going to want to make sure that I'm okay. And so I did go out of my way to make that point to you that this is not a doctor's appointment. It is not your job here today to take care of me. I am here of my own accord with no instruction from you guys. I'm so grateful to have you on the podcast today to share what's actually going on within this policy change and the very severe implications that it's going to have for patients. And none of you had any input for me for how you wanted this to go. So I think that's a very clear example of this being very patient-led, and you guys really taking a step back and understanding where your role is and where your patient's role is, and how you're not directing patients in one way or another.
Why don't you tell people who are watching who may want to join with the advocacy about Lifeline BC? Because when we say organized, we don't just mean they kind of got together and talked. We mean organized, like with a big old...
So I'm not going to lie, I was really hesitant to join the advocacy, and so I don't feel like I'm the best person to speak on Lifeline, because it wasn't until this week that I said, okay, the government's forced my hand, I'm in. Like, I was saving my spoons and you know, my energy envelope and trying to focus my energy back in on me and my health and my family, thinking that there was no way that this was going to go through, and that I didn't need to spend my very limited energy resources on the advocacy. And then this week, when I found out that it is in fact set up to go through, and that despite having your big study and all of the proof around financial savings, this policy was still going to be going into effect. And so that's when I said, okay, you need someone for the news, I'm in. Like, okay, you want to come on the podcast? Please come on my podcast. Let's talk about this. So Lifeline BC is a grassroots patient-led group that has been guiding me every step of the way when I'm emailing my MLA. That's my biggest connection to Lifeline BC, is that when I email my MLA and he comes back to me with questions that I don't have the answer to, and then I contact Lifeline BC and I ask them about it, and they come back to me with some of those factual information that I don't necessarily have access to as a typical patient. So I don't think that we need Kate in here for that, you know?
And Dr. McKay and I are so separated from that we know they exist. We know that they're doing fantastic work. We know that they have a bunch of really smart people with killer skills in all kinds of area. that have been extremely important in trying to push the patient perspective. Dr. McKay and I are trying to say, medically, this is super sound. We don't understand why you don't think that this is something you should be using for other clinics to try and expand physician access. And we want to show that it's financially not. If you want to be fiscally responsible, you should have just checkmarked this right away. But it's not our role to try and get the patient experience across. And that's why, to me, it's very insulting that the Ministry of Health and Doctors of BC have not addressed the patient experience at all.
Are you aware of any consultation that the ministry has done or has been doing to consult the people who will be most impacted by these changes?
No.
Yeah, that's what I thought. And what will it mean for the rest of our medical system in regards to over 6,000 patients suddenly flooding a system that can't support them?
Yeah. I think that your dystopian metaphor is because often dollar savings really don't mean dollar savings because there's a capped amount, but the dollar savings are a good surrogate indicator of how much care we are offsetting and making available in other arenas like primary care, referral care, and emergency care. And so $1.2 million per year, on top of providing the care that we do, we make room for $1.2 million of all the other people to do what they do best, rather than being frustrated with not being able to help this patient population.
I'd like to speak briefly to patient safety. So, one of the things you mentioned is that a lot of patients will be going back to the ER. Patients will be spread out between multiple different specialists instead of one cohesive group. So, in my experience, I have had periods where I've had several different specialists all trying to treat a different symptom that is actually all connected, but they're all different specialists, not understanding the connection between them. So they're treating them all individually instead of cohesively as a whole. I've had some situations where I have felt unsafe in medical appointments and with some of the treatment and suggestions or testing suggested or offered to me because of that lack of understanding of how these symptoms come together as a whole. So do you think that's going to be likely for a lot of patients?
Yeah, I think just to give you a simple example, you have chest pain, you go see the cardiologist, they're going to want to do an exercise stress test. Well, an exercise stress test may put you into post-exertional malaise lasting months. Yeah. And so with our shared care model, one of the things that we suggest is when you go to see your specialist, don't bombard them with all of your information. Because a lot of patients have this idea that the more I give, the better it is for the doctor. Doctors don't have that kind of brain space. So what we tell them is go with your symptom, answer the questions, but don't expect the doctor to put it into big context. But before you implement any of the recommendations, come back to us and we'll contextualize them to your illness. The same thing applies in the other way, which is come to us with your new symptom and we can say you're 26, you have chest pain. This is classic non-cardiac chest pain. Breathe through it, practice relaxation exercises. Don't even bother seeing your family doctor. But if you were a 55-year-old diabetic with hypertension, we would say, even though this sounds like non-cardiac chest pain, we need to have this ruled out, see your family doctor. So not only are we helping patients contextualize the care that they get from other physicians, we're also serving as a kind of, gatekeeper. Steward to care about when to go to the emergency, when to go. In fact, one of our many things that is on hold is we had a webinar prepared with Karen Ferris, who is a patient advocate and a patient navigator, to talk about how best to get the care and when to use the different aspects of care. That's on hold until we're back. But that's one of the things that we are acting as well as a steward to care for the patient. Again, our idea of the big picture.
When I was in my mid-20s and struggling with a lot of these conditions, not understanding them yet, I collapsed at work and lost my ability to speak. And I went to the ER. And at first, they like rushed me in, like, thinking maybe I was having a stroke or whatever. And then some of these clusters of conditions and comorbidities got mentioned by one of my parents in the ER, and everything stopped. They didn't do a single test. They sent me for a psych eval and discharged me.
Well, that's why we tell patients, don't tell them. And, some of the things, like, unfortunately, many of our patients, because of the psych evals, have been mislabeled as borderline personality disorder. And so when we see patients and they provide that as part of their past medical history, we just delete it, because that's like a passport to poor care, having that label attached to your chart. Yeah. And unfortunately, for many patients, even just ME and FM are passports to poor care.
The number of unsafe and concerning circumstances I have experienced in the ER have led my family and I to have a plan in place for if they find me like incapacitated or unconscious or unable to speak or some kind of circumstance that actually requires them to take me to an ER, we have a list of ERs that they are and are absolutely under no circumstances allowed to take me to. And we've reached the point where, like, my partner has found me collapsed on the floor, unable to speak, and does not take me to an ER.
And that's why we, and it's not the ER it's, often the ER doctors are trying to do the best they can for emergencies. Yeah. And I did a presentation for Emerge Docs a while back, and I jokingly said, you should wear a T-shirt that says "Prepare to be disappointed." Not only you as a patient, but you as a physician, because ER is not the place for our patients to get their basic care.
Yeah.
It's when they have something that needs to be differentiated. And so if we can help them navigate that, as opposed to having just patients flood the Emerge because they don't know what's going on. They're not doctors. And so then we're left with a bunch of patients who really don't need emergency care that are taking up room, but also the patients who need the emergency care are not getting the care that they need. And so it's kind of like a double-edged bad sword.
Yeah, absolutely. I had one experience where I was waiting in the ER. I don't remember what for, but I was calm. I was, able to present myself. I was able to communicate. And I had not seen the doctor yet. The nurse comes up to me with, I don't know if she was a nurse or who she is, but one of the staff comes up to me with some medication and says, here's your medication. And I asked her, what is this? What is this for? And so this is going back to that red flag on your chart, right? I don't have BPD. I've never been diagnosed with BPD. That's not on my chart, but obviously I do have these other anxiety, PTSD type labels red flagged on my chart, because she approaches me and tries to give me a high dose of Ativan. And I said to her, I'm sorry, I'm confused. Like, I haven't seen a doctor yet. I don't understand why I'm being given this medication. I haven't requested this medication. I'm just waiting here for a doctor. And she said to me, well, when the doctor comes, like, he might need to take blood work. And, some people don't really like to have blood work done. So we just thought you should take an Ativan. And I said, I can tell based on the size of this Ativan that this is a much higher dose than is appropriate for me ever. Like, I have once in my life taken an Ativan this size and I was left incapacitated pretty much. And if I take this right now, I will not be able to communicate to the doctor for what I'm here for. And I'm not having anxiety. So I'm really confused as to why you are trying to ask me to take this medication before I've even seen a doctor. And the head staff comes over. What's going on here? What's wrong? And the person said, this patient's refusing her medication. And they didn't care what my opinion was on this, or the fact that I wasn't anxious, or the fact that I knew that the results of me taking that Ativan was going to put me in a situation where I was no longer able to communicate to the doctor why I was even there in the first place. They were just concerned with forcing this medication on me for whatever red flag happens to be in my chart that was not applicable to me that day.
What that speaks to, from my perspective, is a lot of cognitive bias on the part of the care providers, and also early closure. There's all kinds of cognitive biases that occur in medicine, and that cognitive bias is driving decision making that is ultimately unsafe in some instances. So that's what it speaks to me. And also it speaks to labeling, and labeling without any insight. So it's not the best care by any stretch. I kind of see where it comes from, but it doesn't mean that it's the best care. So it's great when individuals like yourself actually use your voice and say, hey, wait a minute, this isn't right. Like, that's appropriate.
And that's why it's also, patient-centered care is not new. It was around when I was in medical school, like a long time ago. And that's why you may have noticed that I almost never give suggestions, right? I give options. And one of the questions that was recently asked, when they were reviewing is, how come you let patients decide to do groups twice or what they want to do? And I said, I don't know about you, but this is not the 1950s. This is patient-centered care. And what we do is we offer options, and we let patients decide which options. Because to us, evidence-based medicine is not randomized controlled trials, because randomized controlled trials for our patient populations essentially don't exist. For us, evidence-based medicine is physician expertise, the best available evidence, whatever that is, and patient values and judgment. And at the intersection of all that is where the patient makes the decision, not the doctor.
And I want to echo that. What is very important in my own care delivery is I'm giving information based on exactly what Ric has just said, evidence that I've integrated, experience that I've integrated, but ultimately an individual needs to make a choice based on values, judgments, understanding of risk versus benefit. And you hear me saying this word all the time. This is an informed consent. You're making a choice that's right for you, given what the information that we've provided. And that's shared care. That's patient-centered care. And I think that I like to talk about it because I think it's so valuable and it's so necessary. We're not someone trying to beat someone over the head, take this drug. It's really
don't take this drug.
Or don't take this drug. Yeah.
Because we have a lot of colleagues who have opinions around naturopaths and around different treatments. And what I tell my patients is, we have a webinar on this, navigating information, which is 3 questions. What's the risk? What's the cost? And how robust is the evidence? If it's free and risk-free, who the hell should be telling you not to try it? If it's expensive or if it's risky, then we probably won't support it unless you happen to be super rich and can afford it. But if it's risky, like some patients will be like, why aren't you prescribing rapamycin? There's a study on rapamycin. Yeah, rapamycin is expensive and it's very risky. It's an anti-cancer agency. So for this one, Dr. McKay and I are going to wait until there's significant randomized controlled trial evidence. But metformin for acute COVID People are using metformin for weight loss. So 2 weeks of metformin is dirt cheap and essentially super low risk. So why wouldn't we offer it? Right? And so, but we have colleagues, and I did a presentation at the evidence-based medicine conference just last summer, and I reminded my colleagues that evidence-based medicine is not the application of randomized controlled trials.
Yeah, yes. I want to share with you a very heartwarming experience. So, I do work for the long COVID web in terms of education. And one of the very prominent researcher who's responsible for long COVID web talked about how she integrates traditional Chinese medicine into her patient practice. And and I was like, wow, thank you. It's so good to hear that it's not just about what we know, it's about what many others know. And it was really heartwarming to hear this incredibly famous research scientist saying this in an Project Echo that I co-chair.
The openness of your clinic to different modalities, to weave different modalities together in this whole body, whole patient perspective has been something that I have not experienced in the medical system before. Yeah, I think it's something we need a lot more of.
I think what it really speaks to is there's the holistic care is not medical care. Holistic care is care of different modalities. And I'm not an expert in somatic therapy, but there's evidence that it works. So integrating all of that is really valuable. And I'm hoping that medical schools are getting better at providing more holistic education about involving all players in all disciplines into caring for individuals.
I like Dr. Morello, our naturopath, who says, physician who thinks he knows everything or she knows everything knows nothing.
Mm-hmm.
I say this often. One of what I think is the most dangerous thing in healthcare and a lot of different areas is not knowing what you don't know. So it's okay to not know everything. None of us are going to know everything. But if you aren't aware of the pieces that you don't know about, that brings in significant risk in how we interact with people and patients and how we direct care, in my opinion.
Mm-hmm.
That's why Dr. McKay and I, some doctors hate it when patients bring internet information or bring information. We love it because I think of all my patients as my research team because I might not have the time to see everything that's out there. And so they come to group medical visit and they say, have you heard of this? I'm like, no. And they're like, send me the thing and come back in another visit and I'll read it and I'll tell you about it. And perfectly honest, some of the things that we do are actually patient initiated in those things that they sent to us that we weren't aware of because it's impossible to read everything all the time. So like I say,
Exactly.
it's a community, not a clinic.
And exactly I wanted to just, sorry, I'll just jump in really
Okay.
quickly. Uh, I'm very humble, and I never know everything, and that's my first line is, if I don't know anything about it, please send me something. I'll read about it, come back the next visit, and I'll have some sort of thought process made up about it so we can work together, right?
Yeah.
So
Yeah,
it's
I've seen that in
important.
both of you.
Yeah.
Yeah.
It's like one patient came and you said, there's a study that shows that azolestine reduces the risk of getting COVID if you snort it. And so I said, really? And I looked at it and the paper's like quite good. And the risk is so low that, it's not 10,000 patients, but so we looked, we called the compounding pharmacy. It's available, but it's mixed with a steroid, which is not good. And we asked, can we get it compounded? But we went to like all that length to see if we could
Mm-hmm.
integrate this in our clinic. In the end, we couldn't, unfortunately.
Mm-hmm.
But that's how it's our team. Our patients are our team.
Yeah, that's amazing. It's just such a wildly different and higher quality perspective, in my opinion, than what most patients are receiving through other sources of non-privatized medical care in BC. So earlier you mentioned that there can be a lot of misinformation and stigma around these conditions in general. And so a lot of ideas around laziness or just lack of motivation. So before reaching your clinic and before my illness like took me out, I ran multiple businesses. I was incredibly involved in my community through various volunteer avenues, especially within the business community, as well as I sat on my local action team for child and youth mental health advocacy on like the board alongside Doctors of BC and some other, counseling programs and things like that. And so do you happen to know very much about your patients from before they got sick in regards to lifestyle, careers, and like what does that look like when they reach your clinic? Because I've heard you say like a lot of your patients have been medical doctors themselves. That doesn't scream lazy to me, you know?
Yeah. Many come with the, unfortunately, the story of what many have experienced. They've been labeled with harsh labels of words that are just completely unacceptable. But as I said, we treat everyone from all aspects of society, their business, their arts, their physicians, their nurses, they have a professional label that's amazing. We're united in that we try to actually acknowledge and recognize the loss that comes from an illness that's devastating and takes you away from the value and what you've been giving to the world, and try to acknowledge, recognize, build in opportunities for like grief work. That's a big one for me, is to give opportunities for individuals to do work on grief, because of you're losing a professional identity for a period, a moment in time is the words that I use. So yes, we often hear these stories of tremendous loss and tremendous labeling.
And that's why, like Dr. McKay said, we have to address the grief. So we have a grief group. And we also want, because we live in Western society, our definition is based on what we do rather than our values. And so one of our psychiatrists who's had a remission runs an acceptance and commitment therapy group, which allows patients to realign their identity with their values rather than what they used to do. But the lazy, crazy faking it, which is I usually say, lazy, crazy faking it, but it also goes to the doctors. So you might say, people ask me, how did you get into this? And the reality was, when I saw patients in the outpatient clinic and I didn't know what the hell was going on, I didn't just say, a lot of our colleagues, the way that it works is we rule out. This is a list of things that we rule out. We've ruled out everything that we know, so we're done. As opposed to, let's explore. And that's how I learned and how I got into this, is just listening to patients. And I said, I don't know anything about this, but let's work together and let's try things and let's try and learn. And so, but one of my colleagues early on, when I was in my 30s, came to me and said, you got to stop seeing these patients. He said, because people are going to think you're flaky. And when I said, well, what I'm hoping is that people know me and respect me, and that I will bring a legitimacy to these conditions, because that's one of the things that we have to fight again, is that these conditions are, number one, not real, and these conditions are, number two, psychological.
And so if they're not psychological, what are they? For listeners who are maybe just getting exposed to this for the first time.
Yeah, it's a good one. I like to try to talk about it systematically, and that this is an illness, multisystemic illness, that has created a situation where there's a lot of neuroinflammatory response, which then triggers on a series of events that are communicated not only by proteins called cytokines, but also by disordered immune cells. So at the end of the day, there are, from top to bottom, all body systems are involved, and in part it's It starts with what I feel is a neuroinflammatory response that is either infectious or traumatic or uh, 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 prior vulnerabilities, genetic vulnerabilities we're recognizing and learning more and more about. So I try to simplify it, but it's actually really kind of complex. So
Hmm.
the experiment, it's a real, the first thing I say, this is a real illness, and these are the things that are going wrong in your mitochondria, those small little organelles that are in your body. The energy currency is not working. That's why you feel so, your muscles are tired. That's why you get more tired if you try to do too much. Your energy or system is not working. And so there's the whole process of simplifying the science of it into a understandable message that really legitimizes that this is a true physiologic alteration in an entire body system. Just to give you an example, for long COVID, there's 7 different mechanisms
Okay.
of how the illness is perpetuating symptoms. So 7 different abnormal physiologic responses that are causing the disturbed situation that an individual with long COVID is living with.
Well, I agree. It's neuroinflammatory immune, but the manifestations are protein. They're everywhere, including depression, anxiety,
Mhm.
PTSD. And that's why certain groups of advocacy people don't like us, because they have obviously been traumatized by having these conditions called psychiatric, but they don't want to recognize that there can be a psychiatric component. What happens if a patient gets into pathologic grief? What happens if this neuroinflammation aggravates anxiety and PTSD? What happens when this patient loses family, friends, career, and they get depressed? And so it's not causal, but it's definitely part of the big picture. But and the fact that we support neuroplasticity techniques to reduce neuroinflammation as a way of getting into remission, that this is misinterpreted by the advocacy groups as us blaming this as a psychological condition.
Hmm.
And so
Hmm.
paradoxically, they're not our fans.
And one of the things that I like to always address, because you get this a lot, an individual will want a test to
Hmm.
say, I have this or I don't have that. And what I like to always emphasize is migraines are a clinical diagnosis. Depression is a clinical diagnosis. Chronic fatigue syndrome is a clinical diagnosis. Long COVID is a clinical diagnosis. And try to take away that binary thinking of, I have to have a test to therefore be valid to have a disease. So the medicine, the art of medicine, before we ever had tests, was diagnosis on the basis of symptoms. And so we make clinical diagnoses and we're comfortable with that. And we
Hmm.
know that a lab test is really is is not going to come for this easily.
And I think a big differentiating factor here is you are equipped to make that clinical diagnosis, whereas most specialists I've come across are not.
That's why it's important to recognize that these conditions are not diagnoses of exclusion, that you do not need a big workup. In fact, because they're syndrome based and diagnosed, that often people go, could this be something else? And the answer is no. Could something else also be going on? Yes. And so, because over 200 symptoms have been described. And so it's easy for somebody to get a new diagnosis mixed in, to get new fatigue, new pain, it's worse than usual. And they'll say, no, that's just your fibromyalgia chronic fatigue syndrome. They end up having cancer, or they end up having
Yes.
hypothyroidism, or they end up. And so a lot of physicians are not well equipped to they either over-investigate or they under-investigate. And that's why, by the time most patients have come to us, they've had $1 million workup, which they didn't need, because the Institute of Medicine report in 2015 made it clear this is a diagnosis, not a diagnosis of exclusion, and you need a minimal workup. So Dr. McKay and I have put that minimal workup on our website, and we include it in the patient's notes so that they can check that they've had these tests done. And every once in a while, we pick a thyroid that's been missed, or recently a hyperparathyroid that was been missed, or a stage 2 kidney disease that was missed because of the vague overlapping symptoms. But it's chronic fatigue and hyperparathyroidism, not or. And so that's the important thing, is to make sure that the basic tests have been done, but you don't need much more beyond the basics.
Mm-hmm. So before we kind of wrap up here, I have a few more like rapid fire questions for you guys. So in regards to the recent media coverage, if you could correct just one misconception from the recent media coverage, what would that be?
I think the misconception of this being an excess cost to the healthcare system, to me, that's not true. And that would be one thing I would like to really make clear.
Yeah, I think I agree. It's not greedy doctors. This, and the other thing that I would say that is really important, why the hell are we talking about cost in the first place? I mean, it does save money, but it's about good patient care and accessibility. And it just happens that we can provide this in a cost-saving manner. But what if we couldn't? Wouldn't this care be worth it anyway if it cost more? Right?
Thank you for that.
Because the patient, there's a value to the patient's lives, and and it's not uncommon. Like, we want people to actually. The other message is, COVID's not going away. COVID exists, and these conditions exist, and so you can you'd be an ostrich like on Bugs Bunny, put your head in the sand, but these numbers are expanding, and we can deal with the crisis now and prepare, or we can see what happens in your dystopian analogy.
Oh, man. So what's one thing you wish every MLA and every British Columbian understood about long COVID, myalgic encephalomyelitis, or chronic fatigue syndrome and fibromyalgia patients?
I'm going to go first, Jane, because I've got mine on the tip of my tongue.
Yeah.
The first thing for me is to realize, like, just recently I had a patient denied disability because they did not meet criteria for long COVID. Well, first of all, there are no criteria, because not only are there no criteria, there's no agreed upon definition.
Yeah.
And there's a difference between post-COVID. So post-COVID clinic is not the same as a long COVID clinic. So post-COVID, what can happen after COVID? Most of the argument right now is around how long you have to have symptoms before we call it post-COVID or long COVID. That's a mistake. It should be based on, what did the virus do to you? And to me, there are 5 categories. First category are people who get tissue damage, like lung scarring, blood clots, inflammation. Second category are people who have triggering of autoimmune diseases, like rheumatoid arthritis, SLE, Sjogren's, Guillain-Barré. Next are people who have the triggering or acceleration of diabetes, hypertension, and high cholesterol. And when I say new, some people can get it for the first time, but other people can actually already have it, and it accelerates the speed to get to strokes and heart attacks. And then we get the people who have triggering psychological conditions like depression, anxiety, and PTSD. And then finally, we have the post-viral syndromes. And that's what the Mayo Clinic calls long COVID, and that's what we call long COVID. I'm not an expert in all of this. And that's why patients will come to me and they'll say, I just read a paper that I have microclots in my brain. And then you read the paper, and the first thing it says is post-COVID / long COVID. So it's probably the people with the clots and the tissue damage, probably not these guys. But that's why, until that gets sorted out, the doctors have a place where they can go and do searches about research papers. And there's something called a mesh subheading. And what that means is that if you call it heart disease or coronary artery disease or atherosclerotic heart disease or angina, that you still get all the right papers. And that's called mapping. And so when you go and you type in long COVID in the database for doctors, it maps to post-COVID, which means that currently the medical research does not make a distinction between post-COVID and long COVID. And I think that we're going to continue to see lots of negative results of trials because of mixing these patients' populations up. And we're going to see lots of confusion of interpretation until there's an agreed upon definition that's based on subcategories of outcome. And so we're not, Dr. McKay is a post-COVID expert. I'm a long COVID expert. And so I know about the post-viral syndromes. Dr. McKay is expert in all of these areas. It's a big thing that I want people to know. But the bottom line is no agreed upon definition, and there are subcategories, and the post-viral is just one. But if you also think about it, blood clots, lung scarring, doctors know how to deal with that. Rheumatoid arthritis, lupus, doctors know how to deal with that. Diabetes, hypertension, high cholesterol, doctors know how to deal with that. Depression, anxiety, doctors know how to deal with that. Post-viral syndromes. And in fact, I won't say which university, but in the US, I was invited to do presentations at a university because their post-COVID clinic had never heard of post-viral syndromes. And so they were taking care of the first four, but they didn't even entertain the idea. They would do tests and say, nope, you don't have anything. You don't have long COVID because your test came back normal. Coming back to the idea of syndrome based. So long COVID, not the same as post-COVID. Sorry, long answer.
That's okay. Jane.
So I've gotten lost in the question. I'm sorry.
Yeah, that's okay.
To Ric.
That's okay. The question was, what's one thing that you wish every MLA and every British Columbian understood about long COVID, myalgic encephalomyelitis, or chronic fatigue syndrome and fibromyalgia patients?
So valid illness is the first thing, because life-changing and needs equity. I think from my perspective, recognition and validation from their elected representative that is elected for this moment, that and equity and also advocacy on their end, right?
Thank you. To speak to one of the comments that Dr. Ric just made was, Ric, you pointed out that doctors don't really know how to work with post-viral conditions. And I remember I was getting tested for MS during all of this. And when I got my negative MS diagnosis, I had such mixed feelings because I was I felt like I should be so grateful that I didn't have MS. And instead, I felt so scared because that meant that nobody was going to know how to help me.
And that's why it's important to frame the testing, right? So when I said, whenever we sent that diabetic patient, we talked earlier about the heart stuff, that we say, I'm pretty sure this is non-cardiac chest pain and in my ballpark, but given your risk factors, we need to rule this out. And so when you get the negative results, be reassured that there's nothing bad going on. So you give them a frame to interpret it. Because unfortunately, if I had one patient who had non-cardiac chest pain, same thing, 17 emergency visits in 1 month. And every time he went to the emergency visit, they told him, you don't have a heart attack. But what he really wanted to know was, what do I have? Because, and that's what I teach my students, is that without presenting the patients with a mental model of their illness, they can't do two things. They can't explain what's going on, and they can't predict what's going to happen. And without giving them a mental model, they'll have one of their own, which is there's something really bad going on and they don't know what it is. And so, and that's when I gave him the explanation of this is a problem with the pain system. Your nerve endings are twitchy. They're sending false information. It's like, oh, So I don't have to go to emergency. And because this is a neuroinflammatory condition, that the stress of worrying and going to the emergency was actually making his symptoms worse.
Mhm.
And so his symptoms improved by 50% with an explanation.
Mhm.
Wow.
And so I can't give the patient a mental model. They cannot explain and they cannot predict. And what prediction are they worried about? There's something bad going on and I'm going to die.
Mhm.
Yeah, absolutely. So, what do you want the Minister of Health and people listening to take away from this conversation today?
Let's put the patients first. Just one simple sentence. Let's put the patients first. It doesn't matter that this is cost saving. Doesn't matter that this is innovative. Doesn't matter that we're providing care that is not available elsewhere. There are other programs, but not what we offer. Doesn't matter that we have really good outcomes. Put the patient first.
I tend to agree with that statement. I think we're unified. It's of what I would say the value of care is the value of the individual patient, and their care matters, and their care matters, and you need to pay attention.
Yeah, because like that young girl who got $1 million treatment, yeah, that was because it was about the patient. And so the Minister of Health shouldn't be having conversations around, you know, putting your care at risk for fiscal responsibility. What about patient responsibility? What about societal responsibility?
Mhm.
Put the patient first. Super simple.
Yeah, as a patient, it feels pretty pathetic.
Mhm.
Yeah. Yeah. So, what message do you think that it sends to other clinicians who might currently be trying to create more accessible and effective models of care, that this can just be removed without consideration?
I think it's fear that what the messaging that's coming now from the ministry of we need to cut this, we need to make this more efficient, we need to cut. Everyone's afraid. So I think fear-based governance is only going to create more problems because fear leads to anxiety, which leads to more reaction, more negative outcomes. So, and if you're going to do that to your care providers, imagine what it must feel like to be that care provider, but also remember the patient. So the patient.
Because there's an old quote. Uh, the uh, the magic of caring for the patient is caring for the patient.
Mm.
Imagine that. That's a
Imagine
wild
that.
concept these days.
It is.
The way I see it is that if other clinicians are attempting to create more accessible and effective models of care like you guys have, and then they're seeing this happen and how it can all be stripped away, we as patients are less and less likely to have more accessible models of care available to us in the future.
That's why it's so confusing, right? Because on the one hand, we're saying what we have is not sustainable and that we don't have enough doctors. And then we have the doctors of BC going, let's go back to 1950s old fashioned in person one on one care when everything else is telling us we need groups, we need multidisciplinary care, we need different ways of engaging the patient and putting them at the center of their care. 1950s one on individualized care is not the answer. It's a gimmick. It's a soundbite.
And we are receiving individualized care through your model. So that part isn't the issue.
Yeah, and the College of Physicians and Surgeons is really clear about that. So I hope that we can actually kill a couple of the misinformation, disinformation that's being spread by doctors at BC and by the Ministry of Health, which is that number one, this is a money grab and that it costs more. And number two, that one-on-one in-person care is actually better individualized care when you can get individualized care. And some things are actually better in groups. And the bottom line is coming back to what we said at the beginning. What about the patient? How come the Ministry of Health and Doctors of BC are not talking about the patient?
Mm-hmm. Mm-hmm. Jane, do you want to add to that at all?
I think I would be saying much the same.
Mm-hmm. Yeah. So, what precedent do you think that this sets for future healthcare innovation in BC if a proven cost saving virtual model like this can just be cut without any accessible backup plan for patients?
It's frightening. And it brings me back to the dystopia. I'm
Well,
scared.
I'm actually not scared.
Okay, that's
Because
that's that's the difference between Ric and I. I'm the scared one.
I'm naive. I
Hmm.
still think that once we get to the right people and they see it, it's like you said, it's a no-brainer. And so if the Ministry of Health thinks we're going away, we're not. It may take us longer. We may have to try different tactics, but this model will persist in one way or another, despite the disinformation that is being. So I may be wrong. I hope not. But given the overwhelming response that we've had from lifelinebc.ca, the patient organization, and I know through hearsay that they have plans to triple and quadruple down. That in my mind, it's not a question of if, it's a question of when. And I'm hoping that we don't have to stop our model for a while and cause significant stress not only on our patients but on the system. I hope that the Ministry of Health and doctors in BC come to an understanding and come to their wits so that they don't cause a problem that doesn't have to be.
Hmm.
I have to wonder as a patient if the Ministry of Health understanding that the patients are living with these severe energy limiting conditions, if they aren't just thinking the patients will burn themselves out and they won't be
Mhm.
able to fight anymore. And then we'll just
Yeah,
get to quietly implement this without any upheaval.
yeah. And that's why I think one thing I don't want our patients to think is that this delay is a good thing. This delay is a tactic. And they're hoping we go away. Dr. McKay and I are not going to stop advocating, and our patients are not going to stop advocating.
Well, I think I speak on behalf of a lot, if not all, of your patients when I express how grateful I am to both of you for all of the continued advocacy that you have been doing, because it really blew my mind to see everything, the lengths that you guys are going to for this, because you confirmed my suspicion today, but my suspicion was already that you could make more money with less headache if you just ditched the quality of care that they're
But we're
asking
not
you to.
we're not doing that.
I know,
Um,
that's what I'm
yeah,
saying.
yeah,
So,
it's not
yeah,
going to
that's my
happen.
point is it's as a patient, it's been really interesting for me to observe the lengths that you guys are going to advocate for this care for us as patients and ultimately for our lives, because I still think people are going to die over this.
That's why it's so disheartening, if not insulting, to be framed as a greedy doctor as opposed to a patient advocate who's actually doing what he's asking the Ministry of Health and the doctors in BC to do, which is
Mhm.
put the patient first. It's so simple.
Before we close today, do either of you have anything else you'd like to add to this conversation or leave with the listeners today?
Just our gratitude for giving us this forum, because I'm not sure how you'll cut this, but it's currently 2 hours and 20 minutes.
It's going to stay pretty long. There is a lot of value in this. And
Uh,
thankfully, my listeners understand that I have concise has never been my strong suit. So that is going to be.
so, so, so you're an antidote to the misleading soundbite.
Yeah.
I'm just worried that the right people will not be the listeners.
Yeah, I understand that as well. And this will get cut down into some more shareable clips that people with lower attention spans and less time can listen to as well. But I'm also going to make it available as the long form content so that people can actually listen to the whole thing if they want to or are able to. And then there's none of that misinformation that gets spread when you cut certain pieces and people don't have access to the full conversation and the full story.
Well, that's what, one of the things, and I don't know how media works because Dr. McKay and I are not savvy in that area, but it'd be great if the news media outlets could access this and cut out the pieces once they get the big picture and put those in front of the public.
Absolutely. Well, if they want access to it, I can support that and make that happen. Yeah, absolutely. Thank you both so much for being here today. Thank you for your time on a Saturday. This is your own, personal time. And I know that so much of your personal energy and resources have been going into this advocacy to support us as patients. And we're so grateful. Thank you so much for being here.
Back to you.
Back to you, and thank you. Also very grateful.
As always, I am trusting you to take what resonates with you and leave the rest behind. Please be sure to hydrate and care for yourself well, as any of the energetic transmissions, meditations, or self-healing prompts integrate into your system in the coming days or weeks. As with all the work that I do, I ask that this aligns for the highest and best of everyone involved, and I trust that you will only receive that which is in true alignment for you at this time. If this resonated with you, I invite you to consider giving back through your likes, ratings, comments, shares, or subscribes, as those help so much on these platforms. If you're ready to go deeper than what these platforms can provide, I offer ceremonies, workshops, guided practices, and more at www.deniseelysa.com. I look forward to connecting with you there.